Dear nephrology colleagues, welcome to the live 2021 Nephrology Campus. My name is Peter Stenvinkel and I'm greeting you from a really sunny and very warm Stockholm. I co-chair this Nephrology Campus together with Dr. Christoph Wanner at the University Hospital of Wuerzburg in Germany. And it's an honor for us to present to you 18 different webinars on current trends in nephrology. Before we start with the program today, there are some housekeeping rules. You as an attendee, you are automatically muted and invisible. But you should feel free to ask questions via the question field in the GoToWebinar at any time. So it's an honor for me to introduce two distinguished speakers for webinar number 16. At first you will listen to Dr. Christoph Wanner from Wuerzburg in Germany, and then Dr. Andeera Levin from University of British Columbia, Vancouver in Canada. And they will talk to you about diabetic nephropathy and bringing the recent findings into perspective for nephrology. So it's an honor for me to introduce my co-chairman, Dr. Wanner, and Professor Wanner will talk about diabetic nephropathy, new results.
Thank you for this opportunity to talk about diabetic nephropathy. Here first my disclosures, companies who produce anti-diabetic medication. And then I'm coming to the history, the year 2001, where we first found that the blockage of angiotensin II receptor by losartan produced a risk reduction of the primary endpoint, which was dialysis, by 16%. And this was our 20 year of history that we use now, renin-angiotensin system blockade. But there is still something to do. Also, we reached some success. And now we are entering with a new system and the SGLT2 inhibitors, the arena. And here are the three types of studies which have been conducted during recent years. They are in the field of diabetes and they are cardiovascular outcome trials on the top. On the right bottom side, you see the heart failure trials, which are currently ongoing or published. And on the left-hand side, we talk today about the kidney in the primary endpoint, so-called kidney outcome trials with SGLT2 inhibitor, canagliflozin, dapagliflozin, and empagliflozin, whereas in the cardiovascular outcome trials and heart failure trials, the kidney always is in the secondary endpoint, and this is important. So I can already now summarize all these trials recently published, nicely summarized, all the kidney outcomes of the trial published so far in recent 5 years in patients without diabetes using an SGLT2 inhibitor or in patients with type 2 diabetes. And you can see in the DAPA heart failure trial or EMPEROR reduced trial or DAPA CKD trials, they also involve patients without diabetic kidney disease. And then all the other SGLT2 inhibitor trials in patients with type 2 diabetes. The point estimate of all these trials, the primary endpoint, is far from left of unity. They have narrow confidence interval. In part, they are quite consistent in their results, and the relative risk reduction is around 40 to 50%. This is something we have never seen in history of trials, so consistent results, despite some different underlying cause of kidney disease and pathophysiology. So actually, the SGLT2 inhibitor in patients with and without kidney disease are reducing kidney outcomes in a relative consistent and prominent way. And this appears to be twice as high as what we can achieve with renin-angiotensin system blockade. So this has already gone into guidelines, and here are recent KDIGO guidelines, and the SGLT2 inhibitor is coming on eyesight with RAS blockade and should be applied to most patients on top of standard of care, what you can see on the bottom. And this is reflected also in other guidelines, and guidelines are quite consistent. Now, the question is, why is this so good? And some of the recent hypotheses say that there is also a metabolic switch in the kidney, which results in increased renal gluconeogenesis, a build-up of energy and glycogen stores. The kidneys use less glucose, more short-chain free fatty acids and amino acids. And by this way, they go into hypometabolism. They reabsorb less glucose, have less energy consumption, less oxidative phosphorylation, which is that it increases cellular longevity by generating less reactive oxygen species. So we go beyond our hemodynamic hypothesis that we have less single nephron hyperfiltration and reduced intraglomerular pressure due to the activation of the tubular glomerular feedback. So more hypotheses. I give an intermediate summary always also that you block glucose reabsorption, you improve the energy balance within the kidneys. It causes, of course, osmotic diuresis and natriuresis, the blockade of the glucose reabsorption. It also has some impact on the heart, decreases left ventricular and diastolic pressure and venous congestions of the kidney and a subsequent decline in heart rate. From hyperfiltration, we go into, and hypermetabolism, usually we go into hypometabolism, and we have less tubular stress, and we send the kidney in summer sleep, estivation. The SGLT2 inhibitors clearly have demonstrated kidney safety and a kidney protective effect in patients with CKD and also in patients with HFrEF and recently announced HFpEF on top of standard of care therapies. So recently we were looking also into the mediation of here in the EMPA-REG outcome trial, empagliflozin treatment on kidney outcomes. Why is it so good? And we found an association of one unit change of variables with risk of kidney events. You see on the left-hand side the variables, which are resembled under glycemia, vascular tone, lipids, kidney, adiposity, and volume status, and others. And you see in a time-dependent Cox regression, the most prominent variables which cause a reduction in the kidney outcome here in the univariate analysis, and the landmark trial on the right-hand side from baseline only to week 12. And when you look on the next slide on the multivariate analysis, then you can see on the left-hand side in the time-dependent Cox regression analysis, most effects are explained by an increase in hematocrit. So what is behind this increase in hematocrit? What genes are activated? Is it erythropoietin production, HIF stabilization, and a number of other transcription factors which are subsequently activated? This is now our new questions, and this is reflected here and explained by hemoglobin and hematocrit. There is a high residual risk still for CKD progression with current therapies, and we move also into another area of reducing inflammation and fibrosis, and we have recently found the first medication targeting the existing residual risk. And here is the result. You are maybe already familiar. On the left-hand side, the kidney failure, sustained reduction of a 40% decrease in eGFR from baseline by finerenone. And there was an 18% risk reduction, a narrow confidence interval, a very robust signal with a number needed to treat over 3 years. So in the future, we have more instruments to reduce the progression of diabetic kidney disease in our patients. And on the right-hand side, there is also an effect on cardiovascular outcomes. I'm now coming towards the second part of my talk, the temple. We are building up pillars of outcome-reducing intervention, RAS blockade, SGLT2 inhibition, and MRA by finerenone, based on standard of care. So we want to avoid dialysis. And maybe we do not have to talk anymore about evidence, looking at the wealth of evidence, but we talk today on availability, implementation of this knowledge. Of course, we need a drug which can be tolerated very well. So recently we did an analysis in the EMPA-REG outcome looking at the declining glomerular filtration rate at the beginning, with empagliflozin having twice as much dip at the beginning than placebo, and only a minority have more than 30% risk reduction, where most have 0 to 10% decline in eGFR initially. If we look at the curves and see on the bottom those who dip more than 10%, then you can also see that they stabilize after 4 to 12 weeks, and then there is no acute kidney injury and absolutely safety over time. So I suppose not to measure creatinine, just provide the intervention and receive organ protection. So there is also an issue of awareness. People need to be aware of their disease and to be diagnosed. And coming to this part, I have some consideration, a plea for collaboration with our general practitioners, endocrinologists, and diabetologists, saying that, of course, we nephrologists would like to see patients early on the slope, but we are too few to see all type 2 diabetics or all below an eGFR lower than 60. So my plea is, please, all of you, complete the kidney test. And the kidney test is function and albuminuria. You can diagnose diabetic kidney disease by means of these two parameters. You can identify patients at risk and the progressors, and please refer those, because there is a consequence. Treatment can be offered today to the right patients at the best point in time. So there is a well-established link between CKD and diabetes, and 20 to 40% of people with diabetes will develop CKD, but people are not aware. And therefore, today we talk about awareness. The ERA-EDTA is working in this field with a campaign called Strong Kidneys, the European Kidney Health Awareness Days. And we have provided to the community a video about these strong kidneys messages to Europe. The video is available in 17 languages, can be freely downloaded from the website of the ERA-EDTA, or is available in YouTube for everybody for free. And you can select your language. And at the final end of my talk, I would now like to play this short video to you, that you have an instrument in hands to bring awareness to the people in your country. Thank you very much.
Hey you, what do you know about your kidneys? Most likely not too much. You may know that they are located somewhere in the lower back region, and that they play an important role in purifying your blood. Is that it? Well, it's time to take a closer look. First of all, your kidneys are multitaskers. Every day, they filter about 1,800 liters of blood and excrete the filtered waste products and toxins through urine. They regulate your blood pressure, water and electrolyte supply, and build essential hormones. So they are essential for a healthy, functioning body. But in fact, 1 in 10 Europeans suffer from reduced kidney function, and many are not aware of the progressing loss of function, because kidneys suffer quietly in the early stages. And the worst thing is, they cannot recover from a chronic damage. Consequences of kidney problems include edema, itchy skin, fatigue and anemia, high blood pressure, heart failure and weak bones. In the worst case, kidney function has to be replaced via dialysis or a kidney transplant is needed. But what can you do to prevent this? Especially harmful for the kidneys are diabetes, high blood pressure and obesity. Keep an eye on your weight, your blood pressure and blood sugar levels. In fact, many risk factors lie in your own hands, and you can do a lot to keep your kidneys healthy. Besides regular exercise and healthy whole food nutrition, as well as using less salt, you should watch your weight, avoid stress, nicotine, and the overuse of painkillers. Furthermore, a regular kidney checkup can be very beneficial. For risk patients suffering from diabetes, overweight, or high blood pressure, these regular medical checkups are essential. Urine and blood tests give valuable information about the condition of your kidneys. If renal dysfunction is detected early, its progression can be slowed or even halted. Care for your kidneys and support them to do the incredible job they are doing. Because strong kidneys mean better health and more quality of life.
Thank you, Christoph, for excellent talk and also for showing this nice video. I learned a lot from it. Now, before we go on to the next talk, I would like to remind you out in the audience that it is possible for you to ask questions to Dr. Wanner by using the question window. So now it's an honor for me to introduce the next speaker in this webinar, and this is Professor Andeera Levin from Vancouver, Canada, University of British Columbia. And Dr. Levin will talk about bringing recent findings into perspective for nephrology. Andeera, please.
Good morning, good afternoon, or good evening, depending on where you are. It's my pleasure to present with Professor Wanner a dialogue around bringing recent findings into perspective for nephrology. These are my disclosures. I come to this as a clinician, an administrator, and a researcher with diverse grant funding and research support, as well as an experience on steering committees, data safety monitoring boards, and participating in a number of different clinical trials and compounds, all aimed at improving the outcomes of people living with kidney diseases. This audience well knows that chronic kidney disease is a growing public health problem, and we have the dubious honor of starting in 1990 at number 25 in terms of cause of years of life lost, and up to 2015 getting to number 17. And sadly, now most recently, we are expected to be number 5 by 2040. And this is something that we all need to take pause and note about in terms of the seriousness of chronic kidney disease. If you look at productive life years lost due to premature death or disability in 1990 versus 2017, you'll see here that irrespective of the cause of your kidney disease, whether it's type 1 or 2 diabetes, glomerulonephritis, hypertension, or unspecified, across many age groups, this is in fact rising. And this is a problem for all of us in all of our communities. And so if you look at chronic kidney disease, which actually, as we all know, is not one thing, but rather a multiplicity of things from a global perspective, it is common, it is harmful, and I think nicely we now know that it's treatable. It's linked to many other non-communicable diseases such as diabetes, hypertension, and cardiovascular disease. And between and within countries and regions, there's been huge variability in approaches, resources, and policies. As I alluded to, there's a diversity of kidney diseases, be they acute or chronic, and the role of healthcare systems and multiple partners in preventing and controlling chronic kidney disease, as well as integrating within national and international management strategies for non-communicable diseases, is really important. All that being said, if you think about how we're going to promote kidney health, we need to be aware of it. That is, define the problem and the burden of disease, identify causes and risk factors, and germane to this conversation, generate solutions. And to do that, we need to develop and test interventions and implement them, evaluate them in practice, redefine what problems remain, and then reevaluate. If we think about the cost of treatments, I don't think that we necessarily highlight them to policymakers when they're making decisions on investments. And while dialysis as a salvage therapy is a wonderful thing to look at, it's also incredibly expensive. And identifying and preventing progression are much less expensive. And this is something that we really need to focus on. In 2017, we got together clinicians, researchers, translational scientists, industry, and other people to identify and address gaps in care, research, and policy. And in that symposium or 2-day summit, we actually came up with 3 main goals. One was to improve an identification of chronic kidney disease and reduce risk factors, improve the understanding of causes and consequences, and develop and test new therapeutic strategies. And importantly, today, we can actually say that we have begun to work our way truly towards each of these in a meaningful way. Clinical trials in nephrology have suffered from a culture of complacency, an adherence, or a emphasis on thresholds and targets. And in the beginning, we had many, many negative clinical trials. Some of this due to endpoint and study design issues, but sometimes just because compounds did not work. And that led to the complacency, a knowledge void, and poor engagement for clinical trials, making it hard to recruit and many compromises in study design. However, over the last 15 years, certainly there have been increasing numbers of studies on specific conditions within chronic kidney disease, in dialysis, in transplantation, in diabetes, in acute kidney injury, and in GN. And the number of preclinical studies is also increasing. So there is hope, and that gives us a new perspective. And now we have biomarkers, genetics, an improved understanding of the value of biopsies for diagnoses and prognoses. Through biopsies, we've also started to identify therapeutic targets with molecular diagnoses. And we've got novel study designs for complex interventions, adaptive designs, platform and cluster randomization, all of which lead us to be able to much more clearly and nimbly identify what works and what doesn't in terms of new therapeutic strategies. Ultimately, this leads to more clinical trials, more opportunities, more targets, and an increasing emphasis on best designs and methods. And if one looks at a systems biology and kidney diseases approach, you'll look around the world and you'll see that there are now GN networks, transplant networks, consortium of people trying to answer important questions to identify new targets in both rare and common diseases, and as a consequence, new therapeutic strategies. The Kidney Precision Medicine Project, funded by the National Institute of Health in the US, is an important milestone in nephrology in that it aims to ethically obtain and evaluate human kidney biopsy specimens from patients who have either acute kidney injury or chronic kidney disease in the context of diabetes or hypertension. This will create a kidney tissue atlas, be able to define disease subgroups and identify critical cells, pathways, and targets for even more novel therapies. And this, again, is really important in the context of our perspectives in nephrology. We've recently published a consistent definition for clinical trial outcomes, the first ever international consensus definition for kidney failure to be defined in clinical trials. And this was a Herculean effort by a number of different people, including patient partners, to really try and harmonize all of the clinical studies that we're doing by getting some common definitions for clinical trial outcomes. Now, when it comes to some really amazing new things in the world of nephrology, the SGLT2 inhibitors have multiple ways to improve outcomes. Others in this symposium, and we'll speak much more in detail about this, but through a multiple mechanism, SGLT2 inhibitors improve the outcomes of patients living with kidney disease and cardiovascular disease in a multiplicity of ways. And new paradigms that we now have looking at ACE inhibitors and angiotensin receptor blockades, SGLT2 inhibitors, and non-steroidal mineralocorticoid receptor agonists are actually now very clearly conflated or put together in such a way that we can address inflammation and fibrosis, hemodynamic factors, and metabolic factors all in one individual. These are drivers of CKD progression, and together addressing these in a multiplicity of ways with these three big buckets of agents is really incredibly important in terms of both kidney protection and cardioprotective effects. And this gives us a really different kind of way to approach kidney diseases. What I haven't had time to do in a short period of time is give you the perspectives in 2021, looking at all of the different aspects of chronic kidney diseases. With acute kidney injury and the new nomenclature, acute kidney disease, we have an increasing opportunity to recognize these conditions and therefore manage them better. There are, as this audience well knows, new approaches to anemia in terms of IV iron and the HIF PHIs, and these are also offering a different kind of hope to patients. We know more about inherited kidney diseases, polycystic kidney disease, Alport's, and others, and for these conditions, we have new approaches and therapeutic options. And for chronic kidney diseases and those with diabetes, we have novel agents that reduce both progression of cardiovascular disease and progression of chronic kidney disease. And at the fundamental base of many of this, we've learned how to engage patients both in helping us to define important questions as well as get answers. And in this context, we think we offer a very different kind of hope in 2021 that we perhaps were not able to do even a decade ago. There are more studies and more compounds, and I thought that if I went to clinicaltrials.gov, looking at the number of trials by discipline in 2020, a remarkable year for all of us, and you look at the proportionality of cancer, heart, and kidney, while we still lag behind, I think importantly underway are over 1,000 randomized controlled trials. And this is truly a changing landscape in nephrology, where hopefully through iterative and rigorous study questions and answers, we really will get somewhere different. We've also recognized the importance of implementation science and the need for us in nephrology to develop and expand our armamentarium in this realm. We need to figure out how best to implement strategies within clinical trials and tailor to local circumstances so that we can actually increase the uptake of what we now know are very valuable and important compounds for our patients, and include implementation strategies in the guidance documents that we are publishing so that people have a how to, not just a what to. And again, this is important in terms of changing the outcomes of people living with kidney diseases. So if we look at how we've been changing clinical practice, we have increasing clinical studies in all populations with kidney disease. We have learned how to design studies better. Our conclusions and results, I think, are robust, and we understand why these are impactful, but this new data really does give us truly new hope. In order to tip the balance towards better care, we need to have a firm commitment to more evidence base and acknowledge the diversity across cultures, resources, and access to care. Know that all of our patients will not respond to the same therapeutic strategies, and customizing care will be important. And always taking into perspective patients, providers, and funders is also critical. And so if we think about perspective in nephrology in 2021, I think that you will all agree, and after Dr. Wanner's presentation highlighting some of the really exciting things today, we can look at emerging approaches to improve outcomes in chronic kidney disease and appreciate that it takes all of us working around the world, from basic science to translational science to implementation science, no matter where you are, resource poor or resource rich environments, to actually make a difference. So with that, those are my perspectives in nephrology and how they have changed over the years in 2021. Thank you very much for your attention.
Thank you so much, Andeera, for this excellent talk about perspectives for nephrology and bringing us so much hope for the future. It's now time for maybe the most important part of this webinar, and this is the opportunity for everyone out there in the audience to ask these distinguished lecturers your questions about perspective in nephrology and SGLT2 inhibitors. So are there any questions for Dr. Wanner and Dr. Levin? What factors account for the increased life years lost in those aged 40 to 79 years?
Great question. A lot of that data comes from global burden of disease, so that granularity is not as clear as I would like it to be, but I think a lot of it is attributable to infection and cardiovascular death. The same things that actually are contributing to death on with dialysis patients, but it's actually occurring in the non-dialysis patients as well.
Thank you, Andeera. I'm sorry for these internet connection problems that we seems to have, but let's see if we can get in contact with Dr. Wanner again. Is there any more questions? This is we have this same question for you, Dr. Wanner. Did pheneneron impact albuminuria or the urinary albumin-creatinine ratio?
Finerenone usually reduces albuminuria by close to 30%. And this has been already shown in phase 2b trials, as well as now in the Fidelio trial. So yes, it reduces UACR.
Thank you. Can I have the next question, please? It's again for you, Christoph. How prevalent are EGFR dippers in chronic kidney disease? Is there a difference between diabetics and non-diabetics?
It has been hypothesized that the dippers are more pronounced in patients with type 2 diabetes because of these maximal activation of the transporters. And if you block them, you get really a response at the macula densa. However, the first data in DAPA-CKD show that you have a dip at the similar magnitude in non-diabetic kidney disease. And so it affects about 30% of all patients you treat with an SGLT.
Okay, thank you, Dr. Wanner. We had some internet problems here, so it was hard to hear everything. But let's see if we can have the next question, please. This is for you, Dr. Levin. Is there any data to suggest that public health strategies have worked?
So actually, yeah. In fact, there are places, so the UK, Thailand, and other places have actually demonstrated that having policymakers appreciate and pay attention to chronic and acute kidney diseases does in fact lead to improved awareness and treatment. Now, it takes a long time, as you well are aware, to impact large populations in terms of 5 to 10 years, decades. But public health strategies in other conditions like diabetes and cardiovascular disease have had an impact, as in cancer and HIV. So those are other exemplars that we can look at. Depends on your definition of worked. I think it's a place to start. And in the absence of public health strategies, I think that we will always be inheriting sick people who have lost the window in which we could actually intervene.
Thank you, Andeera. Can I have the next question, please? This is for you, Dr. Wanner. Is being an EGFR dipper clinically relevant, or does it affect drug treatment?
Actually, after extensive experiments or investigations now, and also analysis of the Canvas studies, there is a consensus also with the cardiologists who see the dipper in heart failure patients that there is no harm, and the dipper actually is not connected to the outcome, and is a phenomenon what we see through the activation of the tubular glomerular feedback. Anyway, I think we have to not to think back at the times where we used RAS blockade and recommended to measure creatinine after 1 week and potassium. Actually, I think for easy use of SGLT2 inhibitors, we can neglect the dip and just provide organ protective therapy. But so far, this is a consensus, and I think we have to build this up in nephrology and not go down the old pathways.
So, Christoph, I have a question myself here, something that I have asked many times, but I never gotten a good answer in this, and but maybe you know. Is there an exaggerated effect of SGLT2 inhibitors in those that are regular coffee drinkers? I think in theory it should be some additive effects, but are you aware of any such data?
Not at all. This question comes in the moment as a surprise to me. If you have a good hypothesis in the background, we should investigate this. Maybe there are some trials who have collected nutritional questionnaires. So does caffeine modulate the tone of the vas afferens or efferents, or what is the hypothesis behind this question, Peter?
I would think that stimulation of adenine could have additive effects here with regular caffeine intake. But I have looked for studies and I have not seen any on this, but as you also as an expert on this area has not seen anything, I think this could be open for research. I think it would be an interesting question to try to answer.
The initial osmotic effect is variable and ranges from 200 in some people up to 600 ml in the early days, and bothers sometimes the elderly population. So it's an interesting question, and we should look at this. Good, thank you.
Yeah. So can I have the next question, please? This is for you, Andeera. Of the new paradigms, which approach would you consider the best, or would you consider one better than the other?
So I guess you mean in paradigms, you mean SGLT2 versus non-steroidal MRA. I think they are complementary, most likely, and I would be hesitant. I think I would like to take a step back and say the new paradigm is, let's not just presume that we understand chronic kidney disease in the absence of more detailed information. Where biopsies are possible, it would make sense to learn as much as you can for prognosis and diagnostic reasons. Many diabetics do not have diabetic kidney disease, and many people who look like they should have hypertensive kidney disease have something else. So I think that where we can contribute to increased knowledge and learning, we should do that. And then where we can have disease modifying drugs, we should, that would be the paradigm that I would look at. Not I'm trying to control the blood pressure, the glucose, the proteinuria, but rather I have a disease modifying agent, SGLT2s and MRAs, in the context of various conditions that are valuable. And so those would be the paradigm shifts. And I suppose thirdly, to make sure or look for and seek out opportunities to enter your patients into clinical trials. Until we have a different thought process within nephrology worldwide, being in a trial is better than not being in a trial. I think we're going to always be a little bit behind. And if you look at cardiology and oncology and HIV, all patients were in trials. And I think we really need to, that's the other paradigm. Sorry, that was a bit long-winded.
Thank you, Andeera. I think we have one final last question. And this is for you, Christoph. Did change in eGFR over time affect empagliflozin treatment?
A very good question, because we know from RAS inhibitors, those who dip most have the best outcome. But this is not the case in SGLT2 inhibitors. At least in the EMPA-REG outcome trial, we have not found such a connection between the dip and outcome. I know that others are trying to investigate this as well in other SGLT2 inhibitor studies, but so far we haven't seen this dipping connecting to an outcome. So unfortunately not.
And I guess I would just add, Christoph, Peter, like I think that this, the nephrologist preoccupation with the dip is like, I think it's, we need to A, not look for it, and B, realize that it doesn't predict outcomes, but I think that there's a lot of anxiety still around the dip. And Christoph in his talk suggested not to measure, and that is our clinical practice, is not to measure. It's not like an ACE or an ARB where the potassium will go up and that's also what you're worried about. So there's no reason to double check. And I think that might be an important message for the audience.
Okay, with this I would like to thank you both Christoph and Andeera for these erudite talks, and also for bringing us hope for the future treatment of chronic kidney disease patients. And I would also like to thank all of you attendees for participating in this 16th webinar. I'd like to remind you that number 17, webinar number 17 will occur August 15th, and this will be shared by Professor Christoph Wanner. And this is Dr. Peter Kotanko and Dr. Nadia Grobe that will discuss about precision medicine and the Renal Research Institute. And finally, before leaving this webinar, we still have spots for attending the Life 2021 Nephrology Congress. So save the dates. The registration is open. And this Congress will occur between September 15th to 18th in this fall. So thank you so much for attending this webinar.